Great, thank you. Good morning, everyone. So you're here for the Kaiser Southern Regional meet and greet with CWDA and CFPIC. This is the last of our Kaiser County meet and greet series that we've been doing this month. So we're excited to be here. My name is Beljeet Handel, and I'm your CWDA and CFPIC CalAIM consultant. So I've been working and assisting both organizations work with counties around the MOU and implementation and providing technical assistance around all the initiatives of CalAIM. I'm going to hand it over to Laura.
Good morning, everyone. Thank you so much for being here. Laura Kriswicki with CFPIC. For those of you that aren't familiar with Child and Family Policy Institute, we work and support older adults, child welfare, and other public programs administered by county health and human services agencies. And so, as Baljeet mentioned, we're happy to help host these along with CWDA. We will be putting in our website. We're going to share a link to our website here for a moment, just so I can kind of point out where some of our resources are and where some of the resources after this meeting will be located. If you go and click on our website, Peter, are you able to screen share that real quick? So we will drop, Peter dropped the link of our CFPIC website on in the chat. So if you have colleagues that maybe missed today that you want to share some of this information with, you can see the adults IHSS health plan meetings. Peter, if you want to click on that. We had, for example, the Kaiser meet and greet with the northern counties just earlier this week on Wednesday. We have that video up as well. And so this is where this presentation will be hosted after the meeting today. All of the questions that are asked today, either in the chat, feel free to drop them in the chat, and then there'll be time for Q&A the last 30 minutes of the presentation today. Those questions we will also put together and host them on our website. So if you want to go back later and look at those as well. And so I think that's it for us, and we can go ahead and kick it over to Kaiser, Baljeet.
Just real quick, I'm going to ask Renita to introduce herself.
Hi, everyone. My name is Renita Polk. I'm the Deputy Director of Aging, Disability, and Older Adult Services with CWGA. So happy Friday. Good to see everyone.
Great. Thank you. So I'm going to hand it over to Kaiser, and I think Vanessa.
Put a Monday date, just be safe.
Thanks, Baljeet. Hi, everyone. Happy to be with you all. And as we're pulling up the slides here, just want to introduce myself, and there's several Kaiser Permanente folks on the line, so we'll invite them to come off of mute and say hello as well. We could advance. So my name is Vanessa Davis, and I'm a director with our Medi-Cal program at Kaiser Permanente. I am joined here by several colleagues. My portfolio includes our external local stakeholder engagement and other strategic external initiatives, including our incentive payment programs. And I work really closely with all of our different Medi-Cal teams to make sure that we're developing meaningful relationships to support the level of collaboration that's really needed in the new kind of CalAIM and broader Medi-Cal transformation environment. Lana, do you want to introduce yourself, Lana?
Thanks, Vanessa. Hi, everyone. I'm Lana Trope, and I am our MOU Implementation Senior Manager. Our team is accountable for the MOU operationalization, post-MOU execution. We'll be sharing a little bit about our MOU workgroup today and provide an overview of our MOU execution and our implementation processes. Thank you. I'm going to pass it over to Lev.
Good morning, everyone. My name is Lev Melnichuk, and I'm the IHSS and Child Welfare Medi-Cal Contract Manager with KP team. I Prior to joining KP, I actually worked with DHCS as a contract manager. And prior to that, I actually worked as an IHSS social worker for a local county here for over 7 years. So I'm very happy and excited to be here to present to you guys. And I'll pass it on to Phil Perez.
Good morning, everyone. My name is Phil Perez. I am the liaison here at KP that covers IHSS, but also regional centers, long-term services and supports, and targeted case management. So we're going to focus on IHSS today, but just so you're aware, we also work with those within those other domains as well. I cover Northern California. If I didn't say that already, sorry. And I'll pass it to Ingrid.
Hi, my name is Ingrid Smith, and I cover the Southern California of the same domains. I met a couple of you yesterday on a few meetings regarding the support that we do with the MOU team, as well as with individuals that are receiving IHSS supports. I have over 30 years of experience in the community, so being able to guide and direct members through support.
Ingrid, I think we missed the last part of your intro.
No, I said I'm great to be here. Great to be here is what I said. Sorry.
Thanks,
On
Ingrid.
to you, Vanessa.
No problem. Okay, so just to ground us in Kaiser Permanente's mission, really is, Kaiser Permanente exists to provide high quality, affordable healthcare services and to improve the health of our members and the communities we serve. We can advance slide. Thank you. So, as part of our commitment to serving our communities and really ensuring we can provide high quality, affordable care, we went through a very extensive process and a pretty significant transformation effective earlier this year, January 1st, where Kaiser went into a single direct contract with the California Department of Healthcare Services, or DHCS. And the contract is really focusing on being able to provide coverage and care for Medi-Cal enrollees in 32 California counties. So there's several kind of elements of the direct contract, but in essence, it has expanded Kaiser Permanente's Medi-Cal services from 22 counties to 32 counties. Importantly, it allows Kaiser Permanente to offer Medi-Cal coverage in all areas of the state where we had offered commercial healthcare coverage. And then it extends the specialty care to non-members in selected areas through community partnerships and some really innovative pilot programs, such as the Population Health Management Initiative. Next slide, please. So this is just a map of our Medi-Cal coverage footprint for Kaiser Permanente. You'll see the Northern California counties listed up top, and then in Southern California, we have over 600,000 Medi-Cal members, and you'll see the list of Southern California counties listed below. In total, we have over 1.1 million Medi-Cal members with Kaiser Permanente. An advanced slide. All right, so this is just a look at who is eligible for Medi-Cal enrollment into Kaiser Permanente. So there's several different buckets, if you will, of folks who are now eligible to become KP Medi-Cal. So the first is really focusing on that continuity of care and coverage. So those who have had Kaiser Permanente coverage, say with a different insurance product through the marketplace or through an employer-based coverage within the past 12 months, and they lose that coverage, they would be eligible to come into KP Medi-Cal. Those who are qualified through family linkages of existing Kaiser Permanente members, and you'll see some additional detail on what is included with regards to a qualified family linkage. The third bucket is around foster youth. So foster youth and former foster youth up to age 26. And because of the family linkage eligibility criteria, it's those foster youth family as well. And then finally, those who are duals, so both covered through Medicare as well as Medi-Cal. Additionally, earlier this year with the direct contract, there's growth that may occur through through auto assignment or what's considered default enrollment. And this is really going to vary at the county level, primarily driven by capacity within the delivery system within that specific county. So next slide, please. All right, so we wanted to take a little bit of a deeper dive into some of the work that's happening, being led by the Department of Healthcare Services with the Medi-Cal transformation. So Medi-Cal transformation, also known as CalAIM, is a multi-year initiative by DHCS aimed at transforming the Medi-Cal program in California, essentially to improve health outcomes and address health disparities among Medi-Cal beneficiaries. So there are three primary goals of Medi-Cal transformation. The first is around identifying and managing member risk and need through whole person care approaches and addressing social determinants of health. The second is around moving Medi-Cal to a more consistent and seamless system through reducing complexity and increasing flexibility. And then the third goal is really around improving quality outcomes and driving system transformation through value-based initiatives and modernization of systems and payment reform. So there are multiple initiatives. There are 11 initiatives within the Medi-Cal transformation universe, if you will, but we wanted to focus on a few of them for this conversation. I think we maybe skipped ahead a slide. All right, thanks so much. Okay, so we wanted to talk about some of the work with enhanced care management and community supports, but just to anchor sort of some of this work, we wanted to talk about the different levels of care management. So a big focus of Medi-Cal transformation is really identifying and managing that member risk, as I mentioned earlier. And so through an initiative, another Medi-Cal transformation initiative, Medi-Cal members are screened and assessed for risk and are stratified into different risk tiers. So based on the level of risk assessed and the specific needs of that member, the member is then assigned to a care management program. And this is on the left-hand side of the screen. So ranging from basic population health management to complex care management, which is really higher and medium rising risk individuals that provides ongoing chronic care coordination and disease-specific management. And then at the highest level, enhanced care management. So enhanced care management is a Medi-Cal benefit which takes a whole person interdisciplinary approach to care for members with complex medical and social needs. So important to emphasize that ECM, enhanced care management, addresses both these clinical and non-clinical needs through systematic coordination of services and comprehensive care management that is community-based, interdisciplinary, high touch, and person-centered. So members who are enrolled in enhanced care management, this is important, I think, for some of our later conversations around the touch points with the IHSS agencies and services. Members enrolled in enhanced care management specifically will be assigned a dedicated lead care manager. And we think about this lead care manager as sort of the quarterback on the care team. So the lead care manager coordinates with all of the other people on the multidisciplinary care team, including the care that the member may need inside of Kaiser Permanente as well as outside of Kaiser Permanente. So a heavy focus on that face-to-face coordination and really meeting members where they're at to develop care plans, adopt healthy behaviors, support care transitions, and then ensuring that the member gets referred to the appropriate resources and services that could support them, all while connecting the family and other key members of the individual's care team. So community supports are non-medical services, and we'll take a closer look at this in a moment, but these are non-medical services offered to Medi-Cal members, really focusing on addressing health-related social needs. You do not need to be in a particular care management program to receive these services. So this is anyone involved in, at any level of the care management continuum would be eligible for these services if they meet certain eligibility requirements determined by DHCS. So Kaiser Permanente provides these services, community supports, really to improve health, as well as to potentially avoid more costly healthcare expenses. These services are sometimes referred to as in lieu of services, and they're provided by community-based providers that really specialize in providing the specific services. So we'll take, again, a closer look at the 14 different community supports in a moment. And I know later on in our presentation, we'll kind of do a double click on one of them in particular. So we can advance slide. Thanks so much, love. Okay, so before we get into the community supports, just wanted to share out some work that Kaiser Permanente is doing, and we're really excited to be collaborating with different community stakeholders on this. We're focusing on an enhanced care management outreach campaign pilot for foster youth, as well as the birth equity populations of focus. So these are two distinct populations of focus that are eligible for the enhanced care management benefit. And we're really focusing on trying to meet these members and the folks that serve them where they're at to drive referrals and enrollment into the program. So the pilot is really looking at a communications approach, leveraging trusted influencers, trusted messengers in communities to launch a campaign, an outreach campaign through social media to drive awareness, education, and ultimately enrollment into these services. This is something that, again, as I mentioned, we're starting with the foster youth and birth equity populations of focus, but we're looking to learn from this pilot and evaluate its impacts, and if it's effective, potentially expand to additional populations of focus. For this campaign, we are partnering with a nonprofit public health communications firm, Public Good Projects, and as I mentioned, working really closely with our community-based providers embedded in our communities to ensure we have the right messengers, as well as really the right messages to get folks connected to some of these really valuable and transformative services. So we're targeting implementation in Q4. Okay, so we can keep going. Going back to kind of the community supports piece, I mentioned these are non-medical services. There are 14 total, and each of these have specific eligibility criteria from DHCS. The four kind of buckets that the community supports include are supports for housing insecurity. This includes things like housing deposits and housing navigation. The second bucket is around supporting people to remain safely at home. The third is really focused on supports to improve a chronic condition. And then finally, support to recover from acute intoxication. We can transition to the next slide. Thank you so much. Also, this is really a articulation of how Kaiser Permanente has approached offering enhanced care management, community supports, and the community health worker benefit in all 32 counties. So Kaiser Permanente has taken what's called a network lead entity approach to support the development of a robust community partner network to offer these services to our members. So the network lead entity really ensures centralized service coordination through this NLE kind of hub and spoke model. It's important to note that Kaiser Permanente retains oversight of eligibility, member notifications, quality, and grievances. We partner with the network lead entities to ensure we have comprehensive network coverage. So we really leaned on the expertise and services of the NLEs to ensure that we have that comprehensive coverage and enable the timely access to enhanced care management, community supports, and CHW services. And then all of this is really fueled by collaboration with the local community-based providers. So the network lead entities really provide these services in very close collaboration with community-based organizations and other providers with geographic and population of focus expertise. Next slide, please. So the three entities that are serving as Kaiser Permanente's network lead are Full Circle Health Network. Full Circle Health Network has expertise in working with children, youth, young adults, and families, and they are our children and youth and families network lead entity. So for services and supports to support those populations, those run through the Full Circle Health Network lead entity. We also partner with Independent Living Systems, who is a long-standing enhanced care management and community supports provider with Kaiser Permanente, also Independent Living Systems, or ILS, you might hear them referred to as, and then Partners in Care Foundation with significant experience as a network lead entity. And with Partners in Care Foundation, we've been focusing on our Southern California footprint in particular. So next slide. So for those agencies or organizations that are interested in becoming contracted to provide ECM, community supports, or CHW services to KP Medi-Cal members, the first step in that process would be to reach out to the appropriate network lead entity at the contact information included here, really ensuring that you specify what your agency or organization provides, the geography serviced, and of course the population expertise. So next slide, please. We have worked to establish a no wrong door approach for referrals for ECM and community supports. So we accept referrals from any source, the members themselves, providers, family members, community-based organizations, etc. And referrals can be placed through email or phone. So you'll see the relevant Southern California information on the right-hand side here. Next slide, please. Finally, we wanted to make sure that you all have a list of helpful links and contacts for KP Medi-Cal. So we have the link to our Medi-Cal Resource Center, additional information around our direct contract, and lots of other kind of information specific to certain program areas or other resources that might be helpful to have at your fingertips. Just calling out at the bottom here, the Medi-Cal External Engagement email address. We are very actively checking that email address, email inbox. So just know that even though it's a generic inbox, we check it and are very diligent to ensure that we're following up there as well. I know our MOU and liaison team will share contact information, and please don't hesitate to reach out if you do have questions. And with that, I believe I'll hand it over to Lana to talk a little bit more about our MOU execution and implementation plans. Lana?
Thank you, Vanessa. Hello, everyone. As mentioned, Love and I are from the MOU implementation team and MOU contracting team, respectively. As mentioned during introductions, we are here to share a little bit about our MOU work group and provide an overview of our MOU execution and implementation processes. Next slide. Let's start with our MOU journey to today. And since Vanessa has already shared a little bit about our DHCS contracting journey, why don't we skip ahead to the fourth bullet section over here? So the next one over, Vanessa, or Love. Thank you. Sharing a little bit about our MOU workgroup journey, as a result of the DHCS contract signing earlier this year, our MOU workgroup was formed to ensure that there is a team for both MOU contracting and execution and implementation. We are about to complete month 9 into our MOU workgroup journey, and happy to share that we've made much progress into hiring and onboarding team members to support both sides and both bodies of work. Also happy to share that current state, we have a number of MOUs executed. We also have several MOUs in progress of being executed, all while working on standing up work streams for the MOU implementation and operationalization concurrently. I think we already covered that, so we can go ahead and move on to MOU scope and objectives. So just a little bit about our MOU scope and objectives. In regards to scope, we have 9 MOU types for execution and operationalization this year: IHSS, MHP, DMC-ODS, DMC-SP, RC, LHD, CW, WIC, and TCM. Over to you, Lev.
So what are the MOU objectives? It's to clarify roles and responsibilities between MCPs and third-party entities. It's to support local engagement. It's to facilitate care coordination and information exchange for referrals. And finally, it's to improve transparency and accountability for service and care delivery. So who are the KP teams? We have 4 teams, which is the MOU contract management team. The program liaison is the MOU implementation team, which are the MOU coordinators. And finally is the PMG partners, which are the medical group clinical teams. And next slide is the MOU execution and implementation progress. So as a MOU contract manager, we manage contract negotiations, red lines, approvals, and signatures execution. We report to DHCS on quarterly updates. And then post-execution, as contract management team, we manage contract storage, posting for DHCS reporting, and ongoing maintenance. And I'll pass it back to you, Lana.
Thanks, Lev. So continuing with our MOU workgroup roles and responsibilities, our MOU coordinators, I should say, are the members of our MOU implementation team. We are the designated MCP responsible party noted within the MOUs. We also serve as the primary point of contact for KP and our county partners. And as MOU coordinators, we are subject matter generalists. Many of our team members either have direct medical experience and or consulting and implementation experience. We lead the MOU operationalization efforts in partnership with our program liaisons, our care delivery subject matter experts, and our clinical subject matter experts, and ensure that our PNPs and our workflows are in sync with our MOU requirements. In regards to our program liaisons, our implementation team relies heavily on our program liaisons for their care delivery subject matter expertise within their specific programs and domains. For example, IHSS, child welfare, WIC, just to name a few. We rely on our experts to triage issues for care coordination and navigation. And needless to say, our program liaisons are very valuable partners in our MOU work group. Lastly, on this slide, we have our PMG partners. Because KP is very dynamic in that we are a health plan as well as a provider, we are also able to lean into our Permanente medical group partners. These are physicians and clinicians who are able to provide their clinical subject matter expertise. They help us with they help us ensure that our policies and procedures, as well as our care coordination workflows, are up to standard with MOE requirements, best practices, and the highest level of quality of care delivery. Needless to say, very great strategic thought partners for our MOU work group. And I think that concludes this slide. Over to you, Lev.
So next we wanted to talk about the KP MOU execution. So before the MOU is signed, the MOU contract manager at KP will collaborate with our external and partners through the MOU scope. And that's to define collaboration purpose and scope with all parties to begin the collaboration. Then we have the MOU kickoff meeting, is the facilitation of a kickoff discussion with all parties to begin MOU redline discussions. Then we start the MOU red lines. We draft, revise, and finalize MOU terms with all parties towards execution. We address requirement changes and establish amendment process. And finally, specialized by MOU. So the contract managers are specialized by MOU type, for example, WIC, IHSS, child welfare, LHD, and so on and so forth. And then I'll pass it on to Lana for the post-execution process.
Thank you. Just a little bit more here in terms of our MOU implementation team functions after the MOUs are signed. A few requirements for our team for operationalization. In terms of quarterly meetings, we are required to establish these meetings with our counties and agencies to support continuous collaboration and communication. We are also required to provide training and development within 60 days of MOU execution. Excuse me. We will guide our counties and agencies post-execution through workflow and PMP definitions and development. And lastly, as mentioned before, our MOU coordinators, we are the primary point of contact post-MOU execution for our counties and agencies. So you can think of us as your forever person and your forever partner. Back to you, Lev.
So next we're going to talk about the MOU process. And a lot of you already, or most of you have seen this before, but we'll just go over quickly how do the phases of the MOU process look like. So phase one is when the MOU contract manager schedules the kickoff meeting. Then the contract manager maintains execution tracker, leads MOU redlining, manages county MOU correspondences, obtains SME liaison feedback, and sends to legal for material changes. This step also includes the counties doing the same, sending it to their SMEs and to their legal. At this point, all parties agree when the MOU is ready for signature. Then contract manager identifies MOU ready for signature and prepares necessary documents. Contract manager submits the pre-signatory memo to signatory, and then contract manager facilitates the briefing meetings and sends approved MOUs for signature via Adobe Sign. And then contract manager in phase 3 stores executed MOUs and related legal correspondences for future references, plans for annual updates. Then contract management team files executed MOUs with DHCS and posts to kp.org. And then finally, contract manager hands off to MOU coordinator, our implementation team, who schedules quarterly meetings and maintains the ongoing relationship in steady state. And now we're gonna pass it on to our SMEs and liaisons, Ingrid and Phil.
Good morning.
Thank you so much. Appreciate it. Good morning again, everybody. Thank you for being here. Apologies for my raspy voice. I woke up with I don't know if it's a cold or something, but we're powering through here, right? First, just thank you all for being here. Thanks for taking the time on a Friday to come and join us for this and really collaborate, right? Continue this collaboration. And we worked with some of you in the MOU meetings as well, and we're entering sort of a new territory where with CalAIM, right? Where healthcare and social services are interconnected more than they were in the past, right? And there's some overlap here and there, and we're as liaisons, we are trying to make sure that everything is covered, everything is in place, and that everything is functioning properly. So let's go to the next slide here, where we'll talk about the liaison role. So as liaisons, we one of our main roles is to really make sure that we're bringing everything together. So we connect. We're part of a lot of different work groups and team meetings. We partner with communities, with regional centers, with you all, county IHSS departments, TCM, to coordinate care. We support referrals, manage escalations. And so we're really, being part of those meetings, we're familiar with what's going on, sort of checking the pulse of what's going on at the community level. We work with providers as well, direct service providers. We work with ICFs, intermediate care facilities, SNFs, around claims, authorizations, contracting, and things that are going on, trends that are going on at that level as well. So familiar with even as folks are transitioning out of these settings back into the community, IHSS could be something that is really, really important to their care. So it's important for us to know what's going on at that level as well. Internally, what was that? I'll keep going here. Internally, care coordination. So we work with our internal teams as well, healthcare coordinators, social workers, our PMG, our permanent and medical groups, or our physicians. All the systems that we're developing internally, we're part of those teams as well, and play a role to make sure that we're aware and we're familiar with what's going on at the community level, what's going on at the provider level, to make sure that everything is functioning properly. Members, we interface with members. We are member facing as well. We deal with escalations, outreach, referrals, anything that is if something is not going well, right? As this is new across the state for all MCPs and counties. If there are things that aren't addressed yet, wrinkles that haven't been ironed out, they brought to our level, they can come to us and we will help them solve for any issues that come up. Next slide, please. So the KP member is obviously at the core of what we do. They're at the center. So just taking a look at our KP member and an IHSS recipient who's a KP member in this case, they could have a lot of different entities involved in their life who are providing support and care to them. They could have a family member. They could be connected with a regional center, have a service coordinator, be receiving a host of services on that side. They could be working with IHSS, have a social worker there. Other community organizations could be part of their life. They have their physician, their healthcare specialists, their PCPs, and then there's liaisons. We can come in and help with escalations. There's other KP healthcare coordinators as well who play a role. So it can be quite complex when you have a lot of different entities. And to speak to the ECM, we have that kind of there at the center. I know Vanessa spoke to it earlier, but that ECM role is very, very important. As she was saying, it's a Medi-Cal benefit. It's an interdisciplinary approach to address both those medical and those social needs to make sure that things aren't falling through the cracks, right? It's a high touch setup where they're making sure that everything is being coordinated well to support that member. Let's go to the next slide. I'll hand this one over to Ingrid.
Good morning. And as Vanessa stated before, this slide is here under community supports is because we wanted to bring this back to show you how as a liaison or as this member may move through the different types of supports. And today, being IHSS, a service that is very similar to one that is here under community supports, we just wanted to kind of highlight what the personal care and homemaking support is and how it's different from in-home supportive services. But no, if an individual does qualify for one of the 14 supports here, we will, or the liaison will help guide the lead care manager or the healthcare coordinator through this process. Phil, do you want to just share a little bit about the difference in the IHSS supports and personal care?
Sure. Yeah, thanks for highlighting that. That's, am I off mute? You guys can hear me, right? I always forget that piece. Thanks. IHSS and personal care and homemaker services are very, very similar. They're services that are a lot of times in parallel, right? And so the service description is similar. The care provider is different, right? You guys, for IHSS, the individual can choose a family member, a friend, or they can use the provider network. They get to choose that support provider. On the MCP side, the care provider for KP goes through the network lead entity. And so they're the ones who hire out and contract out with their workers. In terms of number of hours and limitations to services, you guys are familiar with the IHSS side, max of 283, and you guys do your assessment. On the community support side, an assessment is done as well. It's really similar to your assessment process. There are different maximum numbers of hours. And we authorize those for 60 days at a time. But the idea is really to provide that supports during that gap. So we would submit a referral, 2 simultaneous referrals, one to IHSS and then one to community supports, so we can get those community supports while IHSS is doing their assessment and going through the process to receive the hours. Once the IHSS is approved, the hours will then transition from community supports over to IHSS.
Next slide, please, love. So here's a story of just, this isn't an actual member, but it's kind of a profile member as to what you may see or we may see for an individual who would qualify under the community supports and or IHSS. As you can see here, a profile of a 78-year-old male who lives alone and has epilepsy and type 1 diabetes as insulin dependent, as well as hypertension. His health is declining, and as his abilities to complete his daily care, he's being affected in his home. He's now not able to cook meals. He misses his medication, and he just needs support in taking showers and attending his appointments. And more importantly, like most people who live at this age, he lives alone. So where are those supports that are there? That's where IHSS comes in. But for KP, if this individual was at his doctor appointment today, what we would do, or a healthcare coordinator would see, oh, this individual needs some extra support. And as the slide that was presented earlier by Vanessa, we would then look at this member to say, how do we move them through? Next slide, please. And so the way that we would move this individual through to find the supports, and as Phil just referenced, is that we would do simultaneous referrals. One, if this member has never had IHSS, we would go through the initial IHSS process, assist and guide him through that. As we know, IHSS is a voluntary service that is set aside, set alone for that member, but we'll make sure that they're connected the right way. What KP would then do, with the help of the lead care managers in the community supports, is ensure and assess them for the service that is needed until the IHSS is assessed. Under the care and personal homemaking service, it could bring in that support to help with cooking, medical appointments, assisting or guiding him if transportation is needed, cleaning the home, any of those things to keep him safe in the home, opposed to going out of home for care. Once the service has been approved by IHSS, the lead care manager would then look at what are some of the needs that this individual may qualify. As we know, the IHSS, typically through the state and CalAIM, is definitely a generic resource where this service is ongoing in the IHSS world, whereas personal care and homemaking is time limited. So that's why we want to make sure that they're getting the supports until IHSS is in place. Next slide. Do we have any questions? Yeah, I was going to stop and say there's some questions before we go on to the next slide and the contact. We'd like to answer some questions, either ones through the chat, or you can just raise your hand about the community care supports in IHSS through Kaiser.
We do have one question here that I see from Priscilla. Thanks, Priscilla. It's a great question. Just Phil, you mentioned once IHSS is approved, community supports hours will transfer to IHSS. Can you share more info on this? Because if SW makes assessments and determines 50 hours a month, but community supports had 100 hours, how would this be handled? It's a great question. So, I mean, I would hope that we would align, right? But I think the reality is that there's always probably going to be situations where maybe the hours are a little bit different. So what would happen likely would be that, so we're charged with not duplicating services. So we can't just continue to duplicate services. And so that's the idea behind providing those services, the community supports ahead of time during that referral assessment process. If the IHSS assessment came back and it was assessed at a lower hours, we would stop the community support hours. They would transition over to IHSS at a lower rate. But if the individual says, "Hey, I absolutely need these services," then they can apply to be reassessed, through your guys' process as IHSS. I mean, we could continue, depending on the situation, we could continue providing some hours to cover that in the meantime, but it's during that reevaluation period. So there are limitations. From my understanding, we can't just continue to provide those as a duplication of services.
And then also, just to elaborate on that question, Priscilla, is that we want to see why under the assessment process, because their assessment process are very similar. We want to know, why did IHSS approve a less amount of hours? What was that need? Maybe there was a personal at the time of your assessment, it could have been something different. So all those things are definitely taken in consideration, but we do try to look at the generic resource to prevent the duplication of services. I hope that answered your question. Do we have any other questions regarding this? Ben?
Yeah, I just wanted to go back real quick because Phil, you know the amount of maximum hours for IHSS at 283. What is the maximum amount of hours for community support?
So I need to confirm that for you. We have some numbers here, but I want to make sure that it's accurate. So let me confirm that for you, and I'll have to get back to you because I don't want to misspeak on that.
Okay, yeah, it's just because I could definitely see some conflict and maybe some issues or concerns as we move forward where maybe the social workers assessment, but you're right, Ingrid, like it's gonna have to be a collaborative effort where the social worker's gonna have to work very closely with the IHSS liaison team from KP and vice versa. So there could be a mutual understanding, but it kind of reminds me a lot of when clients appeal their case because they're not satisfied with the amount of hours and then they take it to a hearing and then here we go with somebody else, another entity trying to kind of step in and trying to determine what the client should actually be receiving based on their needs.
Correct. And sometimes, Priscilla, it's a different service that's needed. It may not always be PA or personal care. It may be nursing. And so therefore, that's another entity that is used opposed to the community support under community. Under community supports, it could be a different agency helping in that. And I know like IHSS has the nursing component, or it may be, for example, if it's an individual who has a regional center diagnosis, they would receive maybe in-home care. So there's many different opportunities around it, but it's not always a personal care need. And that's why we would really sit down and look at what that need may be. But we'll definitely get back to the group in regards to how that service works. Ben, you have a question?
I did. I think it might be an extension of Priscilla's comment. So I'll see if this adds anything or just we need to, continue the conversation later. Right. So there is, as Priscilla mentioned, right, some debate about the assessment process, right? And IHSS comes from a social services perspective, right? Rooted in disability rights model that says, look, this is not primarily a medical decision. This is not just based on diagnosis that you get X number of hours. And so there is some art to that, right? There's a conversation. We're trying to look at those alternative resources and so on. So I guess, and this is maybe something to discuss further, right? What would that coordination look like? So if, to Priscilla's point, someone's appealing the decision that we made, and they're pointing to the evidence that Kaiser authorized additional hours, how is that going to play into that conversation? Are you guys going to come to hearing with us? Are we going to discuss how that assessment is different? So on, right? And I imagine that we could probably continue those examples. So maybe my takeaway question is, we clearly want this for our clients, right? This is really important, especially as we have challenges getting to the rising need in a timely manner. So this temporary solution of providing personal care is fantastic. But we're probably going to have some more detailed conversations about how we coordinate that, particularly if there is any difference in the assessment process, because I believe that communication, particularly if you're stepping down hours, is going to produce a lot of confusion.
Right. And we recognize that. And as we work through this process on the MOU side, these are some of, on the implementation side, these are some of the questions that we're addressing. And what we'll do is take this back to the care coordination team, the ones who actually do the assessment, to get a little bit more details as to what that actually looks like. So we'll make sure that we answer, because I can see that happening just through my experience of going to IHSS appeals, working with other social organizations, which is why I mentioned to Priscilla that there are other services that we really want to see. Is there another community-based organization that can provide that need that's ongoing? Because DHCS under this CalAIM, unfortunately, it is time limited. It either ends annually or it might be one time, whereas some services like IHSS or like Regional Center, they're lifelong. So we want to be able to look at those services that will be able to help the entire individual not just for, as I would always say, like the Band-Aid of the need. How do we do in a trainer-trainer model for long-term care? Okay, so I hope that was helpful.
Yeah, Ben too, and I think these are good points. And you know, I come from the regional center system as well, and there's similar issues, right? Like you have different entities. There's an art to this process, right? There's different entities who are doing assessments, and there could be discrepancies. You know, and I've been part of hearings where they're saying, "Hey, you know, the regional center says this, and the you know IHSS is saying this," and so, and it comes down, you know, each hearing is unique, right? I'm sure as you're familiar with too as well. So I think these are great questions, and then I think this is exactly why we are coming together to try and partner with you all and to collaborate, because this is another level. It's another level of collaboration and coordination with these services, because we're overlapping, and that's the work that we're continuing to work out with you all in these MOUs to talk about these things. Where are the snags? And that's why this liaison role is important, because we are going to be familiar with, you know, the questions that you have and bring these back, and to make sure that our internal processes at KP are in alignment with what's going on out in the community. So I'm taking note of your questions, by the way, as well. Sometimes, you know, we may not be able to give you a direct answer, but I'm taking note of them, and you know, rest assured, these are things that we're going to consider.
We'll probably also want to get to the point where we have a formal standard agreement about what amount or detail of community supports counts as an alternative resource. And that's something that we probably also need to have a conversation with on our side.
Yes.
Yeah, it's
Ben, you
complicated,
said
right?
it very well.
And there's the regional center system, right? That they provide PA as well. So it can get quite complicated.
Yes.
And yeah, the you know, the need for that extra next level collaboration. Good
yes.
points.
Great points. Thank you. Do we have any other questions? All right, Phil, you want to go ahead and close this out?
Sure. Next slide. It's just really information, some fast facts. We have some contact info for you. If we can go to that next slide. There we go. Just information for you here on the left, confirming KP enrollment. And then when you reach out here on this bottom part of that clipboard, these are really important information. If any of your workers are reaching out, this is important information to include, so we can identify, you know, specific members. You know, of course, inevitably we'll get the email, hey, John Smith, and there's 1,000 John Smiths in our system, right? So on the right side, this is just general contact information. Ingrid and I are here at the bottom under Kaiser Permanente IHSS liaisons. Those are our phone numbers there in NorCal and SoCal. And then the liaison email is a box that we both monitor. So, you know, if I'm out, we'd hate for you to be emailing me or Ingrid, and then, you know, you're not getting a response. So, you know, we cover for each other. That's a great email for you to get a hold of us, and we'll answer any questions that you may have. I think that's it from us, from the liaison side. We appreciate your time, and yeah, we'll hand it back over to you all.
Great, thank you. Let me take the pins off real quick. We can see everybody. I just want to open it up for any additional questions from the counties about what you've heard today, maybe about next steps, right? Anything that you can think about. This is the time to ask those questions and get some. You can raise your hand. Yeah.
I got some questions. So I think, just to kind of reiterate what we said, really excited about this opportunity to partner more closely. I really do think this is going to continue to serve our clients, particularly as those needs continue to increase and we see the demographics continue to rise. So really, this is in a spirit of, how do we figure this out? So I guess I have 2 or 3 big questions, kind of policy related or coordination related. The first is, as we mentioned, right? If there are different assessments, how are we going to get on the same page? Or if we're not on the same page, how do we make sure that we're communicating something that isn't going to jam up the appeals process by having different sort of expectations of what that looks like? The second is, how do we share this at a sort of more holistic level, whether it's data sharing, whether it's connections to EHRs. CMIPS does not connect to other systems, and some of our counties are quite large with large numbers. So do you guys have a sense of what that looks like from your perspective? Is that a push-pull? Is that an API integration? Is that a one by one? What's your maybe kind of sense on that direction?
Just to clarify, are you asking the Kaiser team?
Yes, sorry, they was not clear. The Kaiser team.
Yes. Love, do you want to take the first part? And then I'm not sure who's can handle the second.
I honestly would have to take that back. I'm not gonna try to come up with, big answers right away. So we can take that back regarding how we're gonna make these assessments kind of go and work together, so there wouldn't be so many appeals. Because working for HSS previously, I know how bad it can get. So definitely we will be taking this back. And like we mentioned before, these MOUs are going to be just the beginning of these relationships. And then further on, we're going to be writing these policies and procedures together, and the scopes of work and the workflow. We're going to be talking very deeply how this care coordination is going to work. And that's why we're trying to move these MOUs as quickly as possible and to get to collaborate on them, so we can start on this care coordination where we figure out how these assessments are going to all work together. But we will take that back, and like it was mentioned previously in the comments, that these questions and answers will be posted for everyone to see.
I'll just jump in. Thank you, Love, for doing that follow-up too. And we can talk, hit on the data sharing piece, which is another spirit of figuring it out together. A moment, but I think, and we shared this with your Northern California counterparts on a call earlier this week. But I also think we want to make sure that we can kind of collectively lift some of these challenges and opportunities up. We're not necessarily at the sort of solutioning stage, although I have a feeling you have some ideas, right, where we can kind of use the collective brain trust to potentially bring in conversations with other managed care plans, and, where appropriate, if there are additional channels for advocacy or discussion. So just know that that's definitely something that, that's part of why we see the value in some of these conversations, and appreciate you all so much kind of coming together. But just know that we're kind of thinking about how can we use this sort of continuous feedback loop to figure out where are those kind of pain points, whether it's from a kind of it sounds primarily like from an implementation standpoint, like how do we keep the member at the center, and make the systems work for our members and our patients. So I don't know, Emily, do you want to take the data sharing piece to the question?
Hey, Vanessa,
Hi,
I'm not
hear me?
sure. Is
Okay.
Emily here? Emily, you here? Okay.
Can you hear me now? Sorry, I had to,
Yeah,
I'm on my
yeah.
phone, but
It's like I thought you were on here.
perfect. So as far as the data sharing, as Love alluded to, that once we get into the MOU discussion, with the MOU red lines, we'll be going over that with Love. But when it comes to the data sharing, we will certainly schedule a separate meeting with each of the IHSS agency to discuss and understand what each respective agency is able to ingest, what kind of data that we should be flowing in bilaterally. What is Kaiser able to share? Generally, we can provide what we do have our base data elements that we can provide, which is kind of an eligibility file that provides information that, okay, here are the Kaiser members within your county. So we can share that, and hopefully, we can look into adding some of the program enrollments with the indicator that they're enrolled in ECM, CCM, or community support. As far as how we're flowing those data, currently what we're proposing for Kaiser is to share it through SFTP as our vehicle or pathway in sharing that data. So what we are doing right now as we're meeting with each agency is we do have our simple data questionnaire that just kind of asks what kind of, if you're tied into an EHR or HIE, would love to know that, and then asking for your point of contact. So that way we can schedule those discussions to strategize on how we're going to approach the data sharing. So, not sure if anybody has any question about that, but hopefully I provided some good information. I'll return it back to you, Vanessa. Oh, go ahead. Thank you.
Sorry, this is Renita with CWDA. Just wanted to share a little bit about data sharing. So just wanted you all to know that CWDA is also having conversations with CDSS and DHCS about this, because I know there has been a lot of questions about data sharing. And kind of, I think there's been some confusion about who's sharing data with who and how that's going. So just wanted to kind of share FYI that CWDA is also having conversations with DHCS and CDSS about this. So yeah, just wanted to share that piece.
Thanks,
yeah,
Renita.
thank you for sharing. Yeah, and we want to make sure, sorry, this is Emily again. We certainly want to make sure that as we get into those discussions with the respective IHSS agency, is that we are cognizant of what you're able to share, what are you able to ingest, and just make sure that we identify those processes that we're able to operationalize what is required within the MOU language requirements as far as the types of data that we should be flowing and sharing.
Yeah, and just to kind of lift up, I know that some of the counties maybe on the call were part of the CCI. I don't know if it was the CCI program, project, pilot program. But there have been some comparisons to that program and how that worked. And so we were able to get from Anthem a kind of a case example of some of the data that was shared during that program. And so like Renita shared, this has been, this is kind of starting that conversation with the state around how do you share the, data that it doesn't become a burden for any entity, right? And that was big concern with the counties around CMIPS is a limited system. And so how would you share data from a system such as that? Any other questions, comments? Any concerns around this? Anything that you want to lift up? We have a audience with Kaiser, so this is a great opportunity. Ben, I see you coming off mute.
I'm going to say one more thing, just because apparently I'm the person talking. And if anybody feels differently, of course, unmute and share. I think one of the challenges that we're envisioning is we have, as I mentioned, right, and I think this is true for most counties, we have increasing caseloads, right, and there is not the same funding mechanism for our social workers to increase as maybe some other social programs. And so while we really want to coordinate and make sure that we're serving these clients, we don't have funding for this additional coordination at a staff level, right? So there's not another, DHCS is going to leverage, CalAIM funding so we can stand up a staff person. And so I feel like that's a block, right? We want to find ways we can determine efficiency and leverage existing systems, but right, the closer we coordinate, the more time it takes, and the more time it takes, the less time we have for that staff person to be managing whatever else they're doing, county transfers or reassessments. So I hope I'm not speaking only for myself, but I know that some of the concerns we have is how do we staff this at an appropriate level to make sure we're serving coordinated care for our clients, particularly those most in need.
That's super helpful, and I can't say shocking, but really valuable to hear. And I'm curious if that does resonate for folks. I'm assuming it does, but I think this is the kind of feedback that we want to make sure that we're capturing, so that we can kind of think through what are going to be, again, some of these pain points, whether it is resourcing, because time away from clients, patients, to do kind of administrative coordination, et cetera, is in a resource constrained environment is a concern. And so really just appreciate the feedback. Again, don't have a solution here. I'm curious if any of our other AP colleagues want to weigh in, but definitely I think it's something to that we want to lift up. And be mindful of as we're in our conversations around, the MOU implementation and contract negotiations, et cetera. So unless people are just like, Ben is way off here, Ventura County specific. And I
In which
see
case,
Arif
please say something. I don't want to go around speaking for every other county.
Arif, would you like to jump in?
Thank you, Vanessa. And my apologies, I can't be on video today. RF Sheikh with Kaiser Permanente. I just wanted to kind of address, I think that's a really good point about resources. And I think one of the ways that we as managed care plans can partner with our county agencies is to understand what those barriers and dependencies are. So when we have our own conversations, with DHCS, and we do typically have conversations where they ask us about how things are going. And it does help to kind of share this feedback. So we're happy to, as Vanessa said, to lift up, some of these concerns that you all share from the managed care perspective. Sometimes hearing concerns, issues from multiple parties is just helpful for the purposes of, ensuring alignment, ensuring that we're demonstrating, partnership at the local level.
I know that we didn't have a chance to introduce all of the KP folks on the call, but Arif Sheikh is our Senior Director for Medi-Cal Policy and Engagement. So you're hearing it from the right folks in the room, telling you that this is really critical feedback that we need to hear and make sure that we're bringing back and jointly learning together. And again, where appropriate, having those forums to lift up those conversations. Thanks, Arif.
Great, thank you. Anyone else? Questions, comments? All right, well, for the counties, I am going to send out an email right after this with a survey link. Would really appreciate if you could respond to the survey. It continues to help us at CWDA and CFPIC understand the needs of counties as you continue to lean into CalAIM. We do provide technical assistance as well. So myself and Gretchen Schroeder, who's a consultant brought on with CFPIC, she provided the 101 and 201 trainings. You can go to the CFPIC website to get the webinars on those. We're continuing to roll out additional trainings and again, technical assistance. Where do you need help in whatever area around CalAIM? We can assist with that. I appreciate everyone being on the call. I really appreciate Kaiser. This is our last county meet and greet, but I'm sure it's not the last time we get together and have discussions and conversations around this important initiative that is rolling out and being implemented. And so with that, I give you back, it looks like a couple of minutes before 11:30. Have a great rest of your day and weekend. Thank you, everyone.
Thanks, Fauci.
Thank you. Have a
Thanks,
good
everyone,
weekend.
so much.
Thanks,
Bye-bye.
everyone. Bye-bye.